All right, I'm going to go ahead and get started. For those of you who don't know me, my name is Jan McAlister. I am the Southeast Lipid Association president. I want to welcome y'all to Seela Speaks. This is going to be about a 45 minute webinar on preventative neurology targeting the ApoE4 to combat Alzheimer's disease. After this, we'll have question and answer session, and this will be predominantly through the chat messaging on the Zoom. So if you have a question, please submit it through chat. If everybody would please mute their Zoom so that we don't have any outside interference. And I am going to go ahead and introduce our speaker. This is Dr. Kellyann Niotis. She is a first fellowship-trained preventative neurologist specializing in risk reduction strategies for neurodegenerative disorders, including Alzheimer's disease, Lewy body dementia, and Parkinson's disease. She did complete her medical internship and neurology residency at New York Presbyterian, while Cornell Medical Center serving as chief resident. She has also opened the first Alzheimer's prevention program. So Dr. Niotis, I'll let you fill in any gaps in your bio. Otherwise, thank you very much. We appreciate you giving us this talk tonight for Seela Speaks.
Thanks so much for having me. And I just want to say thank you to Greg for the invitation, and special thanks to Tom Dayspring, who really taught me everything that I know about lipids in the brain. The only thing that I will correct is I didn't open the first Alzheimer's prevention clinic. I wish that I did, but that was my mentor, Richard Isaacson. Oh,
you muted.
Okay, here we go.
Let me get other earbuds. Sorry.
Thanks so much for having me. And I just wanted to give a special thanks to Greg for the invitation, and to Tom Dayspring, who pretty much taught me everything that I know about lipids in the brain. The only thing that I will correct about what you said was that I did not start the first Alzheimer's prevention clinic. That was my esteemed mentor, Richard Isaacson at Weill Cornell. But when he left, I did take it over and expanded the clinic to include Lewy body and Parkinson's disease prevention. So today we are going to talk about the hot topic of brain health, and I am really excited to talk to you as a group of lipidologists, because most don't realize how cross-cutting the fields of lipidology and neurology really are. And you will hear me say throughout this lecture that prevention of neurodegenerative diseases is not just our best strategy, it's the only strategy we have right now. And as one of only a handful of neurologists that specializes in prevention, I really need your help. So I hope you learn something. All right. Many people think that the diseases like Alzheimer's and Parkinson's are only ones that affect old people, but that is a big misconception. Today, I want to give you an overview of what neurodegenerative diseases are, and I want to specifically focus on Alzheimer's disease. Then we'll get more granular on risk factors and discuss how the ApoE4 allele can lead to neurodegeneration and can also serve as a potential target for risk reduction management. And finally, if I have time, I will put in a brief plug for preventive neurology, which I believe is the future of neurological care. Okay, so first, what are neurodegenerative diseases? There are many different types of neurodegenerative diseases, but for this talk, I'm going to focus primarily on the most common type, which is Alzheimer's disease, but I will touch briefly upon Parkinson's disease and Lewy body dementia, because as you will learn, these diseases really are on a spectrum. Right now, there are over 55 million people living globally with Alzheimer's disease, and this is expected to increase to 131 million by 2050. In 2022 alone, disease-related costs topped $321 billion in the US, and by 2030, that's expected to rise to $2 trillion. This graph on the left is a graph from the CDC, and it depicts the top 10 leading causes of death in the United States. As you can see here, Alzheimer's disease is the 7th leading cause of death. It kills more than prostate and breast cancer combined. Though there are fewer people that are affected by Parkinson's disease, about 10 million worldwide, it is the fastest growing neurological disease. From 1990 to 2015, disease incidence doubled, and it's expected to double again by 2040. While these numbers are shocking and honestly terrifying, I do want to emphasize that no sum, however astronomical, can really encompass the pain that individuals and entire families experience when someone's suffering from one of these conditions. Okay, I won't belabor this point too much, but I do want to briefly go over the signs and symptoms of these diseases. So starting with Alzheimer's disease, I am sure that this disease hits home to so many of you, and so many of you are probably too familiar with the symptoms, but just to review, the most common symptom is short-term memory loss, with long-term memory often preserved at least until late in the disease. Other cognitive functions can also be affected, like orientation, planning, and problem solving. There are often behavioral and personality changes that can occur, like agitation, paranoia, delusions. These usually happen late in the disease course. Parkinson's disease, on the other hand, is primarily a movement problem. So people will experience rigidity or stiffness in their muscles, resting tremor, which usually is in the hands, and bradykinesia, which is slow movements, as well as shuffling gait. Often patients experience depression and anxiety and a slew of what we call non-motor symptoms, which does include cognitive dysfunction and dementia in up to 80% of people with Parkinson's disease. While the accumulation of toxic proteins, which we'll talk more about, is unlikely to be the cause of any of these conditions, we do see accumulation of different toxic proteins in these diseases. In Alzheimer's disease, these toxic proteins are called amyloid and tau, and they form amyloid plaques and neurofibrillary tangles, which are these black stained specks here in this histology slide. And in Parkinson's disease, the toxic protein that accumulates is called alpha-synuclein, which deposits into things called Lewy bodies, which are pictured here. So as each disease progresses, we see more and more of these toxic proteins that build up, and they build up in certain regions of the brain and lead to neurodegeneration in certain regions of the brain. So here you can see, compared to a healthy brain, what an Alzheimer's disease brain looks like. There's atrophy or volume loss of the brain everywhere, but especially in this area here, which is the hippocampus or the memory center. In Parkinson's disease, on the other hand, you have loss of these. This is a normal, this is someone with Parkinson's disease. You have loss of these dark colored spots, which are the dopamine producing cells that live in the substantia nigra. Because the brain cells are dying, it speaks to why we haven't been able to identify any disease-modifying therapies for these conditions, because we're often treating the diseases or attempting to treat the diseases once the neurodegeneration has already occurred. And once that happened, we don't have any way of bringing the brain cells back, at least not yet. I know I didn't talk much about Lewy body dementia, and that's because while it's technically considered a distinct disease, I don't really believe that it is. I think it's in between Alzheimer's and Parkinson's disease. What happens in Lewy body dementia is that you classically will find cognitive changes first. They usually have visual spatial deficits, and then some point later in the disease, movement symptoms develop, which are similar movement problems that happen in Parkinson's disease. In Lewy body, you actually can see accumulations of both toxic proteins. So you can see Lewy bodies and alpha-synuclein, hence the name, but you also can see amyloid and tau. And in fact, on post-mortem autopsy studies, 50% of Lewy body cases had enough pathology to be considered Alzheimer's disease and vice versa. This is why I really think these things are on a spectrum. In all three diseases, what we do see is neuroinflammation and neurodegeneration. And what's really interesting is that now we actually have ways to measure these factors in the blood. So we can measure neuroinflammation with a marker called neurofilament light, or NFL, not related to the football NFL, and neurodegeneration with a marker called glial fibrillary acidic protein, or GFAP. Most providers don't realize that there's also a commercially available blood test available in every state except New York, because nothing is ever available in New York, through a lab called C2N Diagnostics that can measure amyloid and tau proteins in the blood. And in combination with someone's ApoE genotype, it's 96% specific and 85% sensitive for detecting Alzheimer's disease, compared to more traditional and cumbersome techniques like an amyloid PET scan. Okay, so what moves someone in one direction of this spectrum versus another depends on various risk factors, which some of we'll cover in this talk. But for this crowd of lipidologists, I wanted to point out two things that I think are interesting. Hyperlipidemia has been identified as a risk factor for Alzheimer's and Lewy body dementia. However, in Parkinson's, high LDL cholesterol is actually linked to a lower risk of Parkinson's disease. I have a feeling that this likely reflects the underlying pathophysiology that's driving Parkinson's rather than a true neuroprotective factor, but this remains unclear. Likewise, insulin resistance is a risk factor for all three diseases, but high triglycerides are found in Alzheimer's disease, while low triglycerides have been linked to Parkinson's disease. I've been picking Tom's brain about this for the last year, actually the first day that I met him, and we're still spinning our wheels. So hopefully we'll figure this out one day. I bring this up just to say that the importance of lipids and cholesterol to brain health cannot be understated. Both excess cholesterol and lack of properly structured cholesterol can lead to serious problems in the brain. Okay, back to Alzheimer's disease. So we all learned in medical school and training that amyloid is the cause of Alzheimer's disease. And many of you will remember a year ago when this Science magazine article raised serious questions about the amyloid hypothesis of Alzheimer's disease. For people who don't remember or just don't stay up to date with popular neurology news, which might be the case for everyone on this call, there was a seminal paper published in 2006 out of Vanderbilt University that gave evidence that a specific isoform of amyloid protein led to Alzheimer's disease, which this paper contained fabricated images. So this sent shockwaves through the media and the field as a whole, and it was the talk of the town for a while. This came after the FDA's hotly contested approval of the first anti-amyloid drug for Alzheimer's disease, which was approved based on its ability to reduce amyloid in the brain, which did correlate to some degree with improving mild cognitive impairment, but the medication was approved based on its success in reducing amyloid burden rather than on a clinical measure such as delaying cognitive decline. And if anyone has been keeping up with the science here, probably no one, that's why I'm giving you this talk. Anti-amyloid drugs have some promise in terms of slowing disease progression, but they aren't the holy grail that the field thought they would be. So if it's not amyloid that's causing Alzheimer's or Lewy body, then what is it? What seems apparent is that amyloid and tau pathology are likely downstream, and one or more likely multiple of these pathways are driving the amyloid and tau accumulation or the neurodegeneration directly. That's not to say that the accumulation of amyloid and tau don't lead to their own problems that can contribute to neurodegeneration and cognitive decline, but it probably plays more of a secondary role. Over the years, what we've learned is that Alzheimer's disease is a very heterogeneous condition that shares similar pathophysiological mechanisms with other neurodegenerative diseases like Lewy body and Parkinson's. Various classification systems have been proposed as ways to categorize disease into subtypes based on its etiology, pathophysiological mechanisms, phenotypic presentation, neuroimaging, various biomarkers. All this is to say that as a clinician, what's most important to understand is that the disease may present and progress differently in each patient depending on what factors are at play. So if we really want to help our patients and make a mark in this, we have to individualize our approach and think about what pathways are most likely involved in a particular person. Prior to my current role, which is at Early Medical, I again led the Alzheimer's prevention clinic at Weill Cornell. So at the clinic, which was a combined research and clinical practice program, we studied an individualized approach using precision medicine as a way to reduce Alzheimer's disease risk. In 2019, we published key results showing that it's possible to improve cognitive function and reduce Alzheimer's disease and cardiovascular disease risk in patients with a positive family history of Alzheimer's disease. And what was more interesting is that those who started earlier and adhered more closely did better. So people with preclinical Alzheimer's disease with either subjective cognitive complaints or no cognitive complaints improve their cognition on average by 3.5 years, while those with mild cognitive impairment improved by 6 months. So it's not to say that starting too late isn't worth it. You do get some benefit from it, but the earlier the better. What's also interesting here is that normal patients without any evidence of preclinical Alzheimer's disease pathology also experienced improvement in their cognitive function, which suggests that this type of approach may be effective in non-AD related brain changes in what we call cognitive aging, or what people will say, oh, they don't have dementia, or my relative didn't have dementia, they just had old age and it's normal to have cognitive dysfunction in old age. It's not really normal to have cognitive dysfunction in old age. The key take home here is our approach is not an algorithm. Our recommendations are based on the best available evidence and based on an individual's particular risk factors. And since our patients had to adhere to these recommendations for many years and potentially the rest of their lives, all of these interventions have to be low risk. And many of our interventions happen to center around the ApoE gene, which is what we're going to spend the majority of the rest of this talk discussing. So if we're going to try to prevent Alzheimer's or Lewy body in a seemingly healthy young patient, the first thing we have to understand is who is at risk. And this is a very busy slide, and that's kind of the point I want to make here. This is really complex. There are a lot of different factors that go into our risk assessment, but as a lipidologist, the one that you're going to encounter the most is genetics and family history. And while we aren't going to focus on all of the factors here, genetics really has implications for other risk factors that I highlighted in blue, some of which we will talk about in this next part of this talk. Okay, so I want to talk about the genetics of Alzheimer's disease. There are a few very rare autosomal dominantly inherited genes that are highly penetrant, which means if you inherit one of these genes, the chances that you will get Alzheimer's disease is pretty high, near 99%. And typically symptoms will occur before the age of 65. But these rare autosomal dominant genes only account for 5% or less of all Alzheimer's disease cases. So for the remaining 95% of cases, symptoms don't typically appear until after the age of 65. So this is considered late onset Alzheimer's disease. And late onset Alzheimer's disease is a polygenic condition, meaning there's really no one gene that guarantees you're going to get Alzheimer's disease. That said, around 50% of people with Alzheimer's disease carry at least one copy of the apolipoprotein 4 allele. ApoE4 was identified as a predictor of Alzheimer's disease in the late 1980s by a man named Alan Roses at Duke University. And what many people don't know about ApoE4 is that it not only increases someone's risk of Alzheimer's disease, it also increases risk of Lewy body dementia. So there are three forms of the ApoE gene. There is ApoE2, ApoE3, and ApoE4. ApoE33 is the most common and isn't directly associated with an increased risk of neurodegenerative disease, but please understand that ApoE3 carriers can and still do develop Alzheimer's and Lewy body. They probably just follow a different pathway and therefore are more difficult when we think about them in terms of risk reduction. About 5% of the population is lucky and they carry an ApoE2 allele, which decreases the risk of developing Alzheimer's and Lewy body by about 40%. And if they do develop one of these conditions, it usually isn't until they're in their late 80s. On the other hand, 20 to 25% of the population carries a copy of the ApoE4 allele, which increases risk of Alzheimer's disease somewhere between 2 and 4-fold, and Lewy body somewhere between 3 and 6-fold. It's also associated with an earlier age of onset compared to ApoE3 carriers. And 2 to 3% of the population carries 2 copies of the E4 allele. A famous recent example is actor Chris Hemsworth, who described this realization as facing his biggest fear. Homozygotes for the ApoE4 allele are up to 12 times more likely to develop Alzheimer's and Lewy body, and symptoms usually occur in their 60s. What's really important, and I cannot emphasize enough, is that not all ApoE4 carriers have the same risk of Alzheimer's and Lewy body. This is why I am so hesitant and almost never give the numbers I just rattled off on the last slide to patients when I talk to them about this. In fact, there are now studies that suggest that ApoE4 by itself may not be sufficient for disease, but it depends on the environment and other genes. So for example, ApoE4 carriers without a family history of neurodegenerative disease don't seem to be at an increased risk. This is probably due to other protective genes like Klotho or CTEP loss of function, mitochondrial variants, and others. There's also gene environment interactions that are at play. So ApoE4 carriers are more susceptible to the negative consequences of things like DDT exposure, physical inactivity, and unhealthy diet, tobacco and alcohol use, and insulin resistance. But ApoE4 also varies on other risk also varies based on other non-modifiable factors like biological sex. So female ApoE4 carriers are disproportionately impacted by Alzheimer's disease compared to male carriers. And finally, ethnicity also seems to play a role. So Nigerians and Latino and Latina populations have a lower risk compared to Japanese and Caucasians. Okay. So while I might be able to spin lipids better than most neurologists, I doubt I am schooling anyone on this call who's listening on ApoE's structure and function in the periphery, but I will give it a go. So ApoE is a protein produced by hepatocytes, macrophages, and adipocytes in the periphery. It binds to the LDL receptor-related receptor, aka the LRP receptor in the liver, and that is the receptor that clears most of the cholesterol-rich chylomicrons and VLDL particles. You are all aware that ApoB and ApoA1 are the main structural apoproteins in the periphery. ApoE only serves a secondary function on chylomicrons, VLDLs, IDLs, LDLs, and HDL particles. Structurally, ApoE has 2 arms linked by this central hinge region. The N terminus here is where it binds to the receptor, and the C terminus here is the lipid binding region. The 3 isoforms of ApoE differ from one another by single amino acid substitutions at positions 112 or 158. But these simple substitutions dramatically change the structure and function of ApoE. So a substitution of cysteine at position 158 leads to ApoE2. This leads to decreased binding affinity to the LRP receptors, that denies the liver of cholesterol, which leads to upregulation of the LDLR receptor and therefore lower LDL particle count and lower LDL cholesterol. When we substitute a cysteine with an arginine at position 112, that results in ApoE4. And this actually makes ApoE4 more compact compared to ApoE2 or ApoE3. That leads to better binding affinity to the LRP receptors, which leads to downregulation of the LDL receptor and subsequently higher LDL cholesterol and higher risk of cardiovascular disease. So while diet doesn't dramatically move the needle, compared to ApoE3 carriers, studies show that in ApoE4 carriers, diets rich in extra virgin olive oil and monounsaturated fats show more favorable outcomes in LDL cholesterol and LDL particle counts. Now let's shift gears to something more complex and much more confusing, ApoE in the central nervous system. So what tends to confuse people is that the lipid and lipoprotein system in the central nervous system is fairly independent from the periphery. This is because there is a highly selective membrane here called the blood-brain barrier, which will allow for the passage of some small molecules by passive diffusion and selective and active transport of various nutrients, ions, and macromolecules that are crucial for neuronal function. But most lipoproteins are too big to leave the plasma, so they cannot traverse the blood-brain barrier to enter the central nervous system. Thus, the brain has to produce its own cholesterol through de novo synthesis. No cholesterol is delivered to the brain via plasma lipoproteins. That is so important, and a lot of people don't realize that. Unlike in the periphery, brain lipoproteins are trafficking through the interstitial fluid called the matrosome here, not the blood. In the central nervous system, ApoE is primarily produced by astrocytes, which are these green supportive cells that interact very closely with neurons, which are pretty much the workhorses of the CNS. ApoE is the main structural apoprotein in the central nervous system, and it's present on LDL and HDL particles. There is no ApoB in the central nervous system. Interestingly, some ApoA1 can actually exit the plasma and traverse through the blood-brain barrier and become a component of HDL particles in the CNS. But most HDLs in the central nervous system contain ApoE, but some also contain ApoA1 and some contain both. In terms of function, ApoE functions as a cholesterol transport protein, and it transports cholesterol between astrocytes and neurons. This happens especially during periods of growth and repair, but also for neuronal signaling. You are all very aware how metabolically active the brain is. Since neurons are the workhorses, as I said, they're the most responsible for cell signaling. They have to conserve their energy for that. And in order to do that, they depend on astrocytes to supply them with cholesterol. Astrocytes that express ApoE3 are more readily able to transfer their cholesterol and phospholipids to supply neurons than those expressing ApoE4. ApoE is also responsible for amyloid beta accumulation and clearance, and this seems to follow an isoform-specific pattern, with ApoE4 leading to a higher accumulation and reduced clearance of amyloid beta proteins. More on this soon. Now that you understand ApoE, what it does in the periphery, what it does in the central nervous system, let's discuss how we can target ApoE to reduce risk of neurodegenerative diseases like Alzheimer's and Lewy body. So I alluded to how the structural properties and functions of ApoE4 can lead to neurodegenerative diseases, but in reality, this topic is very complex. I really love this figure by Hussein Yassin, which depicts all of these complex interactions ApoE has with aging, biological sex, diet, exercise, other genes. These interactions lead to altered cellular biology, which is associated with changes in cellular energy preferences, from glucose to primarily fats, cholesterol transport, the immune response, and amyloid beta metabolism. I overly simplified this, but I tried to break down how ApoE4 contributes to neurodegeneration by classifying pathogenic pathways into two different tracks. So we have the non-amyloid or non-toxic protein tracks and the toxic protein tracks. If we were going to talk about all of these pathways, I would be here until the morning. So I will only speak about the ones that are most pertinent to you, lipidologists. So let's talk about lipid metabolism and transport. After the adipose tissue, the brain contains the highest level of cholesterol in the body, approximately 20 to 25% of whole body cholesterol. In the central nervous system, there's two pools of cholesterol. The largest pool, or 80% of it, is mostly inert, and it's present in the myelin sheaths of these cells here called oligodendrocytes. They surround axons and act like insulation to ensure swift delivery of electrical impulses between neurons. The second smaller pool, which is about 20% of brain cholesterol, is more functionally active, and it's extremely important for brain functions like neuronal growth, repair, remodeling of membranes, organelle biosynthesis, and synaptogenesis, so transmitting neurotransmitters between neurons. This pool of cholesterol is primarily synthesized by the astrocytes, but to a lesser degree, and especially early on in development, by the neurons. With age, cholesterol synthesis in the neurons is downregulated, and the neurons become increasingly dependent on cholesterol produced by the astrocytes, which must be transported to the neurons by ApoE HDL particles. Once it's transported by ApoE HDL particles, it's taken up by LDL receptors and other LDL receptor-like proteins. ApoE4 HDL particles are less efficient at delivering cholesterol to neurons. This is where problems arise. So cholesterol synthesis in the brain, and specifically in the astrocytes, is tightly regulated. When intracellular cholesterol levels are low, sterol regulatory element binding proteins will rise, and that will promote cholesterol synthesis and increase cholesterol uptake through LDL receptors. Well, how is cholesterol synthesized? You all know this. So this is a very simplified explanation of cholesterol synthesis via the mevalonate pathway, which begins with acetyl-CoA. There are many intermediate reactions that ultimately produce cholesterol via either desmosterol in the block pathway or lithosterol in the Cann-Dutz-Russell pathway. Important to know that the desmosterol pathway is particularly relevant for the brain. So this enzyme here, DHCR24, also known as selective Alzheimer's disease indicator 1, is primarily found in the brain, and it plays a key role in maintaining balance of cholesterol within the brain cells. In Alzheimer's disease, levels of this enzyme are reduced, and this reduction is thought to be associated with impaired cholesterol metabolism and ultimately neurodegeneration. Again, note here that desmosterol is the penultimate sterol in this pathway. Why is that important? Well, if we understand that the brain depends on de novo cholesterol synthesis, and that desmosterol is the penultimate sterol in the block pathway, then it would seem plausible that desmosterol could be a biomarker for cholesterol synthesis in the brain and subsequently a biomarker for Alzheimer's disease. Well, in 2012, This was the first study to report that plasma desmosterol levels highly correlated to CSF desmosterol levels, and that both plasma and CSF desmosterol levels are decreased in those with mild cognitive impairment and Alzheimer's disease. This was a small study, so these same authors wanted to further validate desmosterol and the desmosterol cholesterol ratio in the blood. So they analyzed 109 different clinical samples, 42 elderly controls, 26 MCI patients, and 41 Alzheimer's patients. Looking here, you can see that the area under the curve using plasma desmosterol and desmosterol cholesterol ratio is 0.8, which is rather high, suggesting that these two markers have the ability to discriminate between controls, MCI, and Alzheimer's disease patients. It's interesting that desmosterol levels start to change during the MCI or early stages of disease. Seems plausible that this could be an early stage disease biomarker. Later, another study, the Helsinki Businessmen study, looked at whole body cholesterol synthesis and absorption of non-cholesterol sterols in the serum of men with Alzheimer's and without Alzheimer's disease. What they found is that desmosterol and lithosterol ratios were lower in those with Alzheimer's than controls, reflecting this altered cholesterol synthesis in Alzheimer's disease. More on that soon. So both peripheral and central cholesterol metabolism is altered in Alzheimer's disease. In ApoE4 related Alzheimer's disease, an imbalance of cholesterol homeostasis in the brain is a key feature. Insufficiently lipidated ApoE HDL particles are smaller than such particles in ApoE3 carriers, and these are a hallmark of ApoE4. When ApoE is not properly lipidated, the neurons and astrocytes can't get rid of excess cholesterol and excess lipids. So these accumulate in little droplets inside the cells. This leads to altered cell membrane composition, oxidative stress, neuroinflammation, lipid peroxidation, and overall cytotoxicity, which can kill the brain cells. But as you also know, ApoE4 leads to elevated LDL cholesterol and ApoB in the periphery. And that is also very likely, at least in part, responsible for ApoE's impact on Alzheimer's disease risk. In fact, hyperlipidemia is an independent risk factor for Alzheimer's disease, even after controlling for ApoE genotype. And hey, this is something that we can do something about. So if hyperlipidemia is a modifiable risk factor for Alzheimer's, then we should try to treat as early as possible, especially in people who are at high risk, like ApoE4 carriers. Well, what do we use? So the drug of choice for primary risk reduction for ASCVD is statins. It's everyone's favorite. And this might be a fine choice for ApoE4 carriers, but I'd like to argue that we should think about this a little bit more. We should really individualize our treatment decisions here. Data on statins and dementia risk are overall mixed. So this study from 2021, this meta-analysis pretty much says some suggest protective benefits, others suggest neutral benefit, some suggest even harmful effects on cognition. Overall, the quality of the studies we have are not very good. But this one in 2022, published in the Journal of the American College of Cardiology, suggests that there is an adverse neurocognitive effect of statin use, which may outweigh the cardiovascular benefit of statins. This was not noted with PCSK9 inhibition. So why does this happen? Statins are non-selectively inhibiting HMG co-reductase. So they're blocking cholesterol synthesis peripherally, but also centrally. Whether they're hydrophilic or lipophilic, it doesn't matter. They can cross the blood-brain barrier and suppress cholesterol production. In those who are at high risk, like our ApoE4 carriers who already have impaired cholesterol synthesis, and transport centrally, maybe we should find a biomarker indicative of cholesterol synthesis in the brain. Well, what about measuring desmosterol levels? Remember that plasma desmosterol and CSF desmosterol are closely correlated, and low plasma desmosterol is a feature of MCI and of Alzheimer's disease. So if cholesterol synthesis is oversuppressed, as suggested by a low plasma desmosterol level, should we reduce our dose of statin? Should we stop the statin and consider another medication? This is all very hypothetical, but I believe that in ApoE4 carriers who already have altered cholesterol synthesis in the brain, we should be monitoring these sterols to guide our treatment decisions. As an interesting aside, this has not been vigorously studied, but we measure sterol markers in all of our patients, and we also did the same while I was at Cornell. And it's not reported, of course, but I've noted clinically that the patients who seem to complain of statin-induced brain fog have either a desmosterol that falls below the 20th percentile, or they dramatically reduced their plasma desmosterol levels. So maybe it is indicative of some sort of altered cholesterol synthesis that's impacting their cognitive function, causing this sense of brain fog. Okay, shifting gears a little. So I want to talk about the immune functions related to ApoE. So ApoE4 was not always a bad guy. In fact, it was believed to convey a survival advantage. In response to endotoxin, ApoE4 starts to aggregate inside our immune cells and our microglia in our brain, which creates an acute inflammatory reaction that causes a release of pro-inflammatory cytokines, which helps the immune system respond more efficiently. Studies show that ApoE4 carriers had better survival advantage over parasitic and bacterial infections. But now that we don't have to worry about infections killing us, we care more about ApoE4's impact on dementia risk. So in the periphery, chronic low-grade inflammation, defined as a CRP above 8, coupled with ApoE4 genotype, increased risk of Alzheimer's more than in ApoE4s without elevation of CRP. ApoE4 carriers are also predisposed to neuroinflammation due to this overly active immune response. And chronic exposure to pro-inflammatory cytokines is thought to cause loss of integrity of the blood-brain barrier, which allows more substances and toxins to cross and injure brain cells. This leads to a vicious cycle of neuroinflammation, which can disrupt transport of key nutrients, glucose, oxygen. This is bad for the brain. We do have a low-risk intervention that may exert an anti-inflammatory benefit in ApoE4 carriers, and that is omega-3 fatty acids. So we know from meta-analyses that the more fatty fish someone eats, the lower their risk of Alzheimer's disease is. Omega-3 fatty acids, what are they? Why are they important? So you all know these are polyunsaturated fatty acids that are essential to the integrity of cell membranes. When we think about the brain, we think about DHA, not as much EPA. And DHA is really important to neuronal membranes, and it helps facilitate neuronal firing. It's also required for amyloid beta clearance and production, and it's also involved in modulation of neuroinflammation. As humans, we don't synthesize much DHA and EPA, so we have to consume it. And in order to get it to the brain, it has to be transported bound to specific phospholipids through the blood-brain barrier. ApoE4 carriers have impaired DHA transport across the blood-brain barrier. So studies looking at baseline CSF DHA levels found that ApoE4 carriers had much lower DHA levels compared to ApoE2 carriers and ApoE3 carriers. We also know that ApoE4 carriers who consume at least one fatty fish serving per week or had a higher intake of omega-3s as as found on the omega quant, or their omega-3 index from their red blood cell membranes, had less Alzheimer's disease neuropathology post-mortem compared to those who consumed lower amounts. So we're still pending results from the PREVENT-E4 study, which is supposed to come out in 2025. This is a randomized control trial that is testing the efficacy of DHA supplementation in healthy ApoE4 carriers. So while we wait for that, what we do know from the studies that we do have are that DHA supplement seems to benefit ApoE4 carriers who are young, so below 50. It has limited benefit to older individuals. It also seems to be true that if you have more advanced Alzheimer's disease, your levels of DHA in the CSF after supplementation are lower than if you had earlier mild cognitive impairment. And this is again likely because of this impaired integrity of the blood-brain barrier and impaired transport of DHA across the blood-brain barrier. So compared to non-E4s, ApoE4s also needed higher doses of DHA to get to the same levels as ApoE3s in the CSF, and that level was around 2 grams daily. The take home here is that there is a complex interaction between ApoE4 status and disease stage, such that the response to DHA supplementation in ApoE4 carriers depends on whether supplementation precedes the onset of neurodegeneration. It also likely requires high doses and a long-term intervention plan. All right, coming to the end. Finally, my quick plug for preventive neurology. In the beginning of this lecture, I mentioned that once the neurodegeneration has occurred, we have no way of reversing that loss. Then we should be starting to think about these diseases before the neurodegeneration occurs. And right now, we're diagnosing neurodegenerative diseases way too late. These diseases start decades before the first obvious symptom. Most people who are at risk go unrecognized, so they aren't aware that there's something they can do to protect their brain. If 45% of people at age 85 have Alzheimer's disease, the disease started at 55 to 65. And if 10% have Alzheimer's disease at 65, then their disease started at 35 to 45. So this is early. In 2020, the Lancet Commission reported that 40% of dementia could be prevented by addressing 12 modifiable risk factors. For example, these included hearing loss, excessive alcohol consumption, depression, head injury, tobacco use, and others. And there are likely many, many more to be added to this list, like hyperlipidemia, low DHA consumption, elevated homocysteine levels. But there are only a handful of neurologists focused on prevention. Preventive medicine as a whole has been on the forefront of our national dialogue, but unfortunately, it's not been applied to neurological diseases, at least not in any robust manner that has gained any foothold in routine neurological practices. But preventive neurology is neurology, and it might even be lipidology. So it should be a part of routine medical care. But unfortunately, without formal training programs and without insurance reimbursements, this is unlikely to change soon. I like to say that we should reconceptualize our thinking around Alzheimer's and neurodegenerative diseases and start treating these conditions earlier. So here's my take home for you as lipidologists. What can you do for your patients? First, you can start by taking a thorough family history and offering ApoE for genotyping. It really bugs me so much when I hear providers say, I can't test for ApoE4 because there's nothing that I can do about it. And I hope that you learn today that there is something that you can do about it, and it may impact your treatment decisions. I hope that I taught you how to at least some degree, counsel your patients on their specific ApoE related risk in terms of neurodegenerative disease, not just cardiovascular disease. We can be more aggressive in our management of elevated ApoB and LDL cholesterol in our ApoE4 carriers, and even at a young age, and especially for women who are at higher risk. I like to throw this maybe controversial one out there, which is consider testing for desmosterol levels in ApoE4 carriers or people who are at risk, especially if they're on statins. If their desmosterol is low, meaning less than the 20th percentile, maybe we can back off the statin or consider an alternate ApoB lowering medication. And please optimize your DHA levels in your ApoE4 carriers, especially at a young age. And that's it. I will open the stage for questions. Thank you, everyone.
Thank you very much. Appreciate it. That was fabulous. The great thing is this is recorded, so you can go to lipid.org and view and listen to all of the Seela Speaks recordings. There are a couple of questions in the chat box. One question was, can increasing ApoA1 with CTEP inhibition transverse the blood-brain barrier and compensate for defect ApoE isoenzymes in the CNS?
That is an amazing question and so spot on. I don't know who asked it, but yes, amazing question. We don't know the answer, but I believe yes. And there's actually a CTEP inhibitor being studied in ApoE4 carriers for exactly that reason. So more on that soon. There might be other people on this call who know more about that than I do, but yes, yes, and yes. And I think it probably would be really beneficial for our ApoE4s.
Okay, next question is around really a two-part question. Lou Melanau, do you want to ask the question yourself or do you want me to read it out loud? It's a little lengthy. I'll go ahead and read. Although ApoE4 tends to be associated with higher incidence of cerebral amyloid angiopathy, I recall reading that E2 patients treated with statins export more amyloid B into the vessel wall, and this might weaken the vessels and lead to more of the cerebral angiopathy. I wonder if you could weigh in on that. And on statins in the E2 carriers, if that could make a difference.
So that's a completely different pathophysiology that we didn't really talk about. So what cerebral amyloid angiopathy is referring to is that there could be amyloid deposition within the brain cells, within the neurons, within the astrocytes, but you can also get amyloid deposition within the microvasculature of the brain. That usually is different than Alzheimer's disease, which is usually different than what we're looking at. And on an MRI of someone's brain, what you usually see is a lot of little black spots, which represent microhemorrhages because these people tend to bleed a lot, which would suggest that maybe if you're weakening the blood vessels more, you may be more predisposed to bleeding, which could be harmful. And I don't have any insight on what would happen specifically for ApoE2 carriers, but I do know that they looked at this. They looked at statin use specifically and CAA and brain hemorrhage, and seems like it was a wash. It seems like statins didn't increase risk of bleeding even in people with microhemorrhages. So I don't know the answer, but seems like statins probably don't have much of an effect on that.
And in continuation with that, he's asking, since the Alzheimer drugs, which are immunotherapies against B amyloid, seem to do little to nothing for Alzheimer's, we know that cerebral angiopathy, the amyloid in the vessel wall is the cause of the vessel weakening. Might these drugs be a tool to reduce the risk of bleeding in the context of that?
I don't know, but they could also do the opposite. So the side effects that we see, and specifically in people who are on anticoagulation or antiplatelets, is that these medications increase risk of cerebral hemorrhages. So in someone with cerebral amyloid angiopathy, if I saw little micro hemorrhages on their brain MRI, I would be very, very reluctant to use it.
All right, next question. Greg Barifka brings up our exercise context here, clinical effects of exercise, cardio, strength training, viewed separately on Alzheimer's progression. How much, how often, what role does HIIT play in this?
Yeah, great questions. So I didn't talk much about exercise, and maybe that's a shame because I really think that exercise is the biggest lever that we can pull in terms of prevention of all neurodegenerative diseases. It's the one thing that no Parkinson's doctor will disagree with is disease modifying for Parkinson's. We know it reduces risk of Alzheimer's and Lewy body, and it seems to be particularly important for ApoE4s. Now, the real question, which is what you're asking, is what is the dose and what is the mode of exercise? And I would love to know the answer to that. We don't have a perfect answer to that. But what I can tell you from my clinical practice is that I really individualize my recommendations for people. So for example, we know that low muscle mass is not a great thing. Low grip strength is associated with a higher risk of dementia. Often women tend to skip out on resistance training and strength building. So we really try to get them to up resistance training, and often they need to cut back on cardio in that setting. I do really, really like high intensity interval training. The data is kind of all over the place, but I personally have noted improvements in terms of cognitive function in our patients. So I am a proponent of it. I think it really helps with improving cerebral perfusion, and the effects seem long lasting, but I don't have an answer to what your real question is, which is how much, how often, and what. And maybe one day I will, but for now I do not.
Well, thank you. I got just two real quick ones. What's your DHA target on omega-3 index for your ApoE patients? And the role of caffeine. What is the role of caffeine in dementia? I think we all want to know that.
Yes. Okay. So for DHA targets, there's no perfect answer here. So I'm going to give you what I do, which is over 10%. And what's really tricky is that, as I mentioned, we're looking at DHA, and when you get an omega-3 index, you're really getting a measurement of both DHA and EPA. So you have to make sure that if someone's getting supplementation, that they're getting the proper amount of DHA. The Omega Quant Complete actually breaks down DHA versus EPA levels. And there's one study that looked at that. It seemed like DHA percentages over 5 were most protective, but I don't routinely check that. I just try to target omega-3 indexes over 10 and make sure that for my ApoE4 carriers, they're getting around 2 grams of DHA. And then in terms of caffeine and coffee, pro caffeine, and actually seems to have a dose dependent effect. And it's not just the caffeine that's good in coffee. So there are a lot of neuroprotective compounds that they've identified in coffee, also in tea, that seem to either work along with the caffeine or independent of the caffeine altogether. But yes, pro-caffeine seems like the magic number is up to 4 cups per day, but it's very individualized because some people can't sleep after 4 cups of coffee per day. So it's really what someone can tolerate. But yes, pro coffee and pro caffeine.
Well, Thank you, Dr. Niotis. There are so many comments on the chat about how wonderful the talk is and how valuable the information is. I'm sorry I couldn't get to all of the questions. NLA has a clear stop point on these because our window with Zoom is only open for so long. But thank you so much for your time and the information. And I look forward to everybody joining us next month, July 18th, for our next talk, talking about imaging and cardiovascular risk. So everybody, y'all have a good Tuesday night.
Thank you so much for having me, everyone.